Okay, so we shall continue with the chapter NSAIDs. So far in the earlier lectures we have covered the non-selective COX inhibitors. Okay, so those agents which can inhibit both the isoforms of the COX, that is COX-1 and COX-2 non-selectively. Okay, but the problem with most of these agents is that they inhibit the COX-1 enzyme, which is constitutive in nature. That means it is involved, the PGs which are generated by COX-1 are involved in the normal physiology of the body. Okay, so that's the major drawback with the use of non-selective COX inhibitors. So to overcome this problem, certain agents were introduced which were selective towards inhibition of the isoform COX-2, mainly which generates the PGs which are involved in the pathological role, that is inflammatory processes and so on. Okay, so there are several further classes. This is the second main class actually, preferential COX-2 inhibitors. So as the name implies, these drugs preferably inhibit COX-2 as compared to COX-1. Okay, so they are more selective. You cannot say that it is totally selective towards inhibition of COX-2, because it can as well inhibit COX-1 also, but it is less likely to. It is more likely to inhibit the enzyme COX-2. That's why they are categorized under preferential COX-2 inhibitors. Now the first example under this is Nimesulide. Okay, now this particular drug Nimesulide, it's a weaker inhibitor of PG synthesis. Okay, so as other NSAIDs, this one also acts by inhibiting the PG synthesis by inhibiting this enzyme. Okay, but it is a weaker inhibitor of this PG synthesis when you compare it with the other NSAIDs. Okay, so also it is moderately selective towards enzyme COX-2. Inhibition of COX-2 is more likely when this particular drug is given. Now, apart from being an inhibitor of PG synthesis, this drug Nimesulide also exert the anti-inflammatory activity by certain other mechanisms as well. Okay, like reduction in the generation of the superoxides. Okay, so superoxides which are highly reactive. So these which are generated by the neutrophils, which are attracted towards that inflammatory site. So these superoxide generation is reduced. Apart from that, it can inhibit the PAF synthesis. Okay, platelet activating factor is also another mediator of inflammation we have seen, and it is synthesized and released locally at the site of inflammation. So this drug Nimesulide can also inhibit the platelet activating factor synthesis, which is one of the mediator of inflammation. Apart from that, TNF alpha, which is another mediator. So TNF alpha release is also inhibited. Apart from that, it has free radical scavenging property also. Okay, and it inhibits the metalloproteinase activity in the cartilage. So resorption is also inhibited. Okay, so these are the additional mechanism of action. Okay, so if the question is asked on mechanism of action of Nimesulide, of course you need to explain the inhibition of PG synthesis through COX and its selectivity, plus additionally these are the mechanisms for its anti-inflammatory activity. Okay, then next coming to the pharmacokinetics, this drug Nimesulide, it is completely absorbed orally, and as you can see the plasma protein binding, it's very high, almost 99% of whatever drug is in the systemic circulation, it is bound to the plasma protein. And metabolism, it is almost completely metabolized and excreted mainly in the urine, and the T half-life is just 2 to 5 hours. Okay, so repeated dosing may be required. Once daily dosing may not be sufficient because of its shorter T half-life. Then coming to the uses, generally this drug is preferred in the painful inflammatory conditions, because it has very good anti-inflammatory property. Okay, so specifically those situations where inflammation is involved, pain which is associated with the inflammation, such conditions can be effectively controlled by Nimesulide. Okay, so examples of these conditions include sports injury, Okay, so when you participate in the sports, you get injured over there. So such kind of injuries, Nimesulide is preferred. Sinusitis, then apart from the sinusitis, other ear, nose, throat disorders or dental surgeries, if at all they are carried out, or bursitis, that is inflammation in the joints, maybe lower backache, okay, or dysmenorrhea, which is a pain associated with the menstruation. Then post-operative pain can also be effectively controlled. Osteoarthritis, and also it can reduce the fever. It has antipyretic property as well. So these are the uses of Nimesulide. Then coming to the adverse effects. So it is categorized separately. Now coming to the gastrointestinal side effects, these include epigastralgia, that is epigastric pain may be felt, okay, that is in the stomach region, in the abdominal region. Heartburn, okay, so severe pain in the chest, okay, may be seen. Then nausea, loose motions are other gastrointestinal complications. And dermatological complications include rashes and pruritus. Okay, so hypersensitivity reactions also can be precipitated. Central side effects include somnolence, that means a tendency to go to sleep. Okay, so sleepiness will be produced, or dizziness may be seen with this Nimesulide. Okay, now though it shows the gastrointestinal toxicity, still the gastric tolerability is better as compared to other drugs. Okay, GI toxicity is less as compared to other NSAIDs, but renal complications may be seen. Okay, that is hematuria, that is blood may be seen in the urine. Okay, this is mainly reported in some of the children. Okay, so also there is a risk of development of fulminant hepatic failure. Fulminant meaning there is a sudden hepatic failure which may develop. Okay, so these are also on record. So for the same reason, this drug Nimesulide, it has been banned in several countries. It is not used in several countries. Okay, whereas it is, of course, it is available in India. Okay, but most of the countries have banned because of these severe side effects which may be seen. Specifically, use in small children is discouraged. Okay, because small children are at a higher risk of development of these severe adverse effects. Whereas if you can see, this drugs use is specifically meant for those patients in whom bronchoconstriction may be precipitated, or those who are intolerant towards the aspirin. Okay, so mostly in asthmatics. Okay, in asthmatics, generally when you prescribe aspirin, an asthmatic attack may get precipitated because it diverts the pathway towards LOX. So it is contraindicated actually in the asthmatic patients. Okay, so in such cases wherein the NSAIDs or aspirin are contraindicated in such situations, this Nimesulide is preferably used. Okay, only in such patients in whom aspirin or other NSAIDs are contraindicated. So you can say that this must be actually a reserved drug because of the severe side effects which can be precipitated. Then coming to the next drug, that is Diclofenac sodium. This again is a very popularly used drug, Diclofenac. Okay, you will find it in many of the analgesic combination drugs also. Okay, coming to the mechanism of action. Okay, as you are already aware of, it inhibits the PG synthesis and it is somewhat more selective towards inhibition of COX-2. That's why it is classified under preferential COX-2 inhibitor. Okay, and because of its selectivity, its antiplatelet action, that is inhibition of thromboxane synthesis, okay, which is involved mainly in the aggregation of platelet. So that is not appreciable with the use of this drug because it is mostly selective towards inhibition of COX-2. So bleeding tendencies are not likely with the use of Diclofenac. Okay. Then apart from inhibiting the COX-2 enzyme, it also follows other mechanism of action like neutrophil chemotaxis, or the superoxide production at the site of inflammation may also be reduced. So these are the additional mechanism of actions which are utilized by this diclofenac for its anti-inflammatory action. Coming to the pharmacokinetics, this drug is well absorbed orally, and again this is 99% bound to plasma protein. So highly bound to plasma protein, metabolized completely and excreted both in bile as well as in the urine. Okay, either of these are the pathways for the excretion of this drug. And plasma T half life, you can see it is just 2 hours. So it is a very, very short acting drug. But there is an added advantage with the use of this drug is that it has a good tissue penetrability. Okay, and it can concentrate in the synovial fluid. In your joints there is a synovial fluid. Okay, so this drug diclofenac, it has a tendency to get concentrated in this synovial fluid, and this particular level of diclofenac in this synovial fluid, it is maintained for 3 times longer period than in plasma. So it will remain in the synovial fluids for a longer period of time. So that's how it is more effective in treating the conditions wherein joint inflammations are involved. Okay, so those conditions which are involving joints, specifically arthritic conditions. So this drug is quite effective in such conditions because it is concentrated, or it will remain over there for a longer period of time. And coming to the adverse effects, these are generally mild epigastric pain or nausea, headache, dizziness and rashes may be precipitated. Then gastric ulceration and bleeding. These are this is a very common problem with the non-selective agents. So this is also less common, whereas this is a problem now. Elevation of the serum aminotransferases may be seen. So this indicates that liver damage may be seen. This is quite common. Even kidney damage is also there, but it is rare to occur. But hepatic damage may be seen. So that is indicated by increase in the levels of serum aminotransferases. Then coming to the uses, this particular drug diclofenac, it is mainly employed in the arthritic conditions, rheumatoid arthritis as well as osteoarthritis. Okay, because it is mainly getting concentrated in the synovial fluid, so it gets accumulated over there, so it will show more prominent action at that particular area. Apart from that, bursitis. Okay, again this is an inflammation in the smaller joints which are used quite frequently. Ankylosing spondylitis, again an inflammatory condition. Okay, or toothache. Okay, it is having analgesic property also. Okay, so it can be used in toothache or renal colic. Even dysmenorias can also be effectively controlled. Post-traumatic or post-operative inflammatory conditions can also be effectively controlled. So it will relieve the pain also, and it will also help in the controlling the wound edema also. Okay, because of its anti-inflammatory property. Then coming to the next drug, that is aceclofenac. This is again a congener of diclofenac, somewhat selective towards inhibition of COX-2, having similar properties, and in addition to that, it can also enhance glycosaminoglycan synthesis. So because of this, it is having chondroprotective property. So again in the arthropathies, again this drug aceclofenac is quite effective. Next drug is Meloxicam. Okay, now if you can remember enolic acid derivatives which are known as oxycams. So this is a congener of that particular class drug. Piroxicam was a drug which we had discussed over there in detail. So this drug Meloxicam, it is a congener of piroxicam. If you can refer the older books, you will find this Meloxicam is classified along with piroxicam and all. But later on, it was found that it has a greater selectivity towards inhibition of COX-2 as compared to COX-1. Okay, so this ratio of inhibition of COX-2 to COX-1, it is about 10. So it is 10 times more potent in inhibiting COX-2 enzyme as compared to COX-1. So that's why it is later on classified under the preferential COX-2 inhibitors. So all the advantages of this preferential COX-2 inhibition will be seen. Its inhibition of platelet thromboxane A2 production. So that is also not quite significant. Okay, so it's an advantage. Then even this drug is effective in the arthritis conditions, osteoarthritis and rheumatoid arthritis. Both these conditions can be effectively controlled by this drug Meloxicam. Then coming to the side effects, gastric side effects, which is a more common problem with the other derivatives, okay, belonging to this class. So as compared to that, Meloxicam it is a milder gastrotoxic agents, okay, but nevertheless long term use of course may produce the ulcer complications. So ulcer may be precipitated if this drug is used for a longer period of time. So as far as possible, avoid the use of this drug for a long period of time. It should be used for the short lasting pain. Okay. Next drug is etodolac. Okay, now this newer agent is an indole acetic acid derivative. Okay, indomethacin again is an indole acetic acid derivative. So this etodolac also is an indole acetic acid NSAID. So again, since it is more selective towards inhibiting COX-2 and it is having similar property to diclofenac, it is categorized over here as a preferential COX-2 inhibitors. Okay. Again, gastric tolerance is better than the older NSAIDs. Okay. So comparatively, it has a better gastric tolerance. That is, gastric erosion or ulcer precipitating tendency is less likely with this drug. Coming to the kinetics, it is metabolized mainly by two processes, that is hydroxylation and glucuronide conjugation, and excreted mainly in the urine with a T half-life of 7 hours. Okay, and if you can see, its duration of action is 6 to 8 hours, specifically in controlling the post-operative pain. It can control it up to 6 to 8 hours. Okay, then the side effects, these include mild abdominal pain, rashes and dizziness may be precipitated, and it is used in the treatment of osteoarthritis, rheumatoid arthritis and acute musculoskeletal pain. So specifically inflammatory conditions, okay, pain which is associated with inflammation can be effectively controlled by this drug. Then coming to the next class, that is selective COX-2 inhibitors. These are also known as COXIBs. So far we have seen non-selective COX inhibitors, preferential COX-2 inhibitors, which are having greater propensity to inhibit the COX-2. But later on, certain new agents were discovered which are having selective COX-2 inhibitor property. Okay, that means they have negligible inhibitory property on the COX-1. Okay, so selectively COX-2 is inhibited, which is actually involved in generation of the PGs which are mainly associated with the inflammatory conditions or pathological conditions. Okay, so several advantages will be seen with the use of these drugs. Okay, so all the complications like gastric toxicities, then bleeding tendencies. Okay, so all those complications will be ruled out with the use of these particular agents. Okay, so currently these three agents are available, three COX-2 inhibitors are available: Celecoxib, Etoricoxib and Paracoxib. So collectively they are known as COXIBs. COXIB is a term which is given to this particular class. So these three COX inhibitors, COX-2 inhibitors are available. Earlier Lumiracoxib also was marketed. Okay, this was banned because of its hepatotoxicity. Again, Rofecoxib, Valdecoxib also are the drugs which were marketed, but later on these were also withdrawn because of its cardiovascular complexes. So in the older editions of the books you will find these drugs which are discussed. Okay, but these are gone out of use because of their high tendency to produce either hepatotoxicity or cardiovascular risk. Okay, now though these selective COX-2 inhibitors, they have several advantages over non-selective COX inhibitors. Okay, several adverse effects may be ruled out with the use of these selective COX-2. Okay, but still, as far as possible, these drugs must be used in patients only who are at high risk of peptic ulcer, perforations or bleeds. Okay, in whom you cannot prescribe the non-selective agents. So in such individuals, these COXIBs are preferably administered. So also one care you should take is while selecting, okay, they should be administered in the lowest possible dose for the shortest period of time, because you cannot rule out the gastric toxicity totally. On prolonged use, it may precipitate the GI toxicity. So as far as possible, use should be restricted only in those patients in whom non-selective agents are risky to prescribe, and if at all they are prescribed, it should be used in lowest possible dose and for the shortest period of time. Okay. So also another precaution which you should take is they should be avoided in any kind of patients who are suffering from any cardiovascular condition, because the older agents, they have gone out of use because of the cardiovascular risk. Okay, valdecoxib and all. Okay, so as far as possible, these drugs should be avoided in those patients who are suffering from some kind of cardiovascular diseases, in whom there is any history of cardiovascular conditions like ischemic heart disease, hypertension, cardiac failure, or cerebrovascular diseases. So in such patients, it is better to avoid these agents. Okay, so this is a contraindication. So also combination with the aspirin, okay, of the COX-2 inhibitors, that is also not advisable. It is not supposed to be combined. Okay. Then there are certain other concerns also with the use of this COX-2 inhibitors, which you should take into mind before prescribing. Okay, that first thing is, these drugs are selective in inhibiting the COX-2. Okay, so COX-1 will not be inhibited, or if at all it is inhibited, that inhibition is not of a significant level. Okay, so the thing is, COX-1 generated PGs, they may also play a role in inflammation. Okay, though COX-1 generated PGs are mainly involved in the normal physiology of the body, still these PGs may also play a role in inflammation. So selective COX-2 inhibitors, they may not be able to control this inflammation which is mediated through COX-1 generated PGs. Okay, so that's a disadvantage with this particular class. Another concern is in case of ulcer injuries and H. pylori. Okay, so those patients who are suffering from ulcer, okay, or ulcers due to H. pylori infection. So in such situations, these two conditions, that is ulcers or the H. pylori, it induces this enzyme COX-2 in the gastric mucosa. Locally, this enzyme is induced. So whatever PGs are generated by using this COX-2 in the gastric mucosa, these are actually gastroprotective PGs. Okay, so they will help in rather healing of the ulcers. So such PGs are also generated with the help of this COX-2 in the gastric mucosa. So when you give the selective COX-2 inhibitors in these two situations, it will delay the ulcer healing. So that's a drawback. Okay. Then another concern is that this COX-2 enzyme, it is constitutive in juxtaglomerular cells, that is in your kidneys. This is playing a constitutive role. That is, a normal physiology is controlled by the PGs which are generated by COX-2 in the kidneys. So when these selective COX-2 inhibitors are used, they will inhibit this COX-2 enzyme which is constitutive in juxtaglomerular cells. So this will result in salt and water retention. So conditions like pedal edema or precipitation of CHF or rise in BP may be seen with the COXIBs. Okay, so these are the three agents as I have discussed earlier. Celecoxib, it is used because it is a better tolerated agent. And one more property with this etoricoxib which you should keep in mind is that it has highest COX-2 selectivity out of all the agents. Okay, then paracoxib is another drug. This is actually a prodrug of valdecoxib which is suitable for injections. Then coming to the last class, that is drugs which are having good analgesic antipyretic property but they have poor anti-inflammatory property. Okay, so under that the first class is para-aminophenol derivatives. Okay, Okay. Now the first agent which was discovered under this class was phenacetin. This was introduced in 1887. Okay, and it was extensively used as analgesic and antipyretic. But then later on this drug was banned because of its tendency to precipitate nephropathy, that is kidney damage was being precipitated by this drug. Okay, because this drug was very widely used, and this drug was abused literally, meaning that for small conditions people tend to take analgesics when it is not required. So because of such abuse, this drug has landed up into precipitating nephropathy in such individuals. Okay, so because of this drug phenacetin was withdrawn from the market and it was banned later on. Okay, and then a new agent was discovered, that is paracetamol. Okay, paracetamol is also known as acetaminophen, which is another name for paracetamol. Now this is a deethylated active metabolite of phenacetin. Okay, so that's an active metabolite of phenacetin. So it was introduced earlier, but then its main use came into picture only after 1950s, and thereafter it has been used very widely, and it is the most commonly used analgesic antipyretics nowadays. You will find paracetamol in almost every house. You will find a paracetamol, okay, because it's available as a over the counter medication also. So whenever you have a fever, first thing you will do is you will take a paracetamol tablet. First name comes to your mind is the paracetamol. Okay, so it's quite effective in controlling the fever. Okay, so it is quite widely used. Now coming to the pharmacology of this paracetamol, the first point we are going to cover is the pharmacological actions. Okay, now this particular drug paracetamol, okay, it has central analgesic action, okay, just like aspirin. Aspirin also we have seen that it has peripheral as well as central component. Okay, so in the same way paracetamol also acts as a central analgesic, that is it will raise the pain threshold, okay, but it has a weaker peripheral anti-inflammatory component. So it's a poor anti-inflammatory agent. It has a very weak anti-inflammatory property. Okay, then the analgesic action of aspirin and paracetamol, it is additive. When both the drugs are given together, their analgesic property will be additive. Okay, then paracetamol, as I have told you, it has a very good and it is a promptly acting antipyretic. So it will reduce the fever very quickly. So it is a quite widely used antipyretic drug, paracetamol. Okay. However, this drug is a poor inhibitor of PG synthesis in the peripheral tissues. Okay, so its central component is more important. It is more active in inhibiting this enzyme COX in the brain. So by inhibiting the COX in the brain, it raises the pain threshold. So that's the main mechanism of action of paracetamol. Whereas I've already told you all that it has a very weak anti-inflammatory property. Now why it is having a poor anti-inflammatory property is that its inability to inhibit this COX enzyme in presence of peroxides. Now generally whenever there is an inflammation or tissue damage at the site, a particular site, okay, at the site of inflammation several superoxides, peroxides are generated. Okay, so this drug paracetamol, it is ineffective in inhibiting this enzyme COX in the presence of these peroxides. So this is the reason why it is ineffective in the treatment of inflammation. So it has a poor anti-inflammatory property. Whereas in case of brain, it can effectively inhibit this enzyme COX because there are no peroxides over there. So this is a theory which has been put forth why it is having poor anti-inflammatory property. Okay. Apart from that, this paracetamol also can inhibit COX-3, so another isoenzyme of this COX which has been recently discovered. So this is the important mechanism for the action of paracetamol. It can inhibit the enzyme COX-3. So that accounts for the analgesic antipyretic property of paracetamol. Okay. Then there are several other advantages also. We have seen under paracetamol that it stimulates the respiration. In higher doses it will depress the respiration. Okay, so such effects on the respiration are not shown by paracetamol. So also acid-base imbalance is precipitated by aspirin. So such acid-base imbalance is also not precipitated by paracetamol. Okay, even it does not increase the cellular metabolism. We have seen under aspirin that cellular metabolism is enhanced. Even aspirin shows the actions on the CVS, but such effects on CVS are not shown by paracetamol. It will not show any actions on the cardiovascular system. Even the gastric irritation, which is more likely, gastrotoxicity is more likely with aspirin, we have seen. Okay, ulcer patients cannot take aspirin unless and until you formulate it in the form of soluble aspirin tablet or buffered aspirin tablets. Okay, so such kind of gastric irritation of this is insignificant with the use of paracetamol. That is mucosal erosion or bleeding. It occurs only rarely, and that too in the overdose. In the therapeutic doses, it lacks the gastrotoxicity. So that's another advantage. Another action is that it does not affect the platelet function or clotting factors. We have seen that in case of aspirin, platelet aggregation is inhibited because it inhibits the thromboxane A2 generation. Even clotting factors synthesis is also getting affected upon prolonged use. Even paracetamol is not uricosuric. We have seen under aspirin it is dose dependent. Okay, so at higher doses it has uricosuric property also. So that is lacked by the use of paracetamol. So several differences in between aspirin and paracetamol we have seen. Okay, such questions may also be asked. Compare and contrast between aspirin and paracetamol may be asked in exam. So there are several points of differences. Okay. The next is the pharmacokinetics of paracetamol. So this drug paracetamol, it is well absorbed orally, and it is almost 1/4 of whatever is absorbed. It is bound to the plasma protein. So plasma protein is just 25% and uniformly distributed throughout the body. Now coming to the metabolism, that's very important. Okay, so metabolism, mainly the main reactions involved in the metabolism of paracetamol is conjugation reaction with glucuronic acid and sulfate. So this is the major mechanism of metabolism. The phase 2 reactions, glucuronide conjugation with glucuronic acid and sulfate conjugation are the important metabolic pathways for paracetamol. Okay, and these conjugates are later excreted rapidly in the urine, and the T half-life of the drug is just 2 to 3 hours. Okay, so it is quite a short lasting drug. So whenever paracetamol is administered, it is supposed to be repeated. Generally thrice daily dosing may be required, okay, with the paracetamol. Okay, then coming to the adverse effects. Okay, adverse effects, as such you can see that there are very less adverse effects. It is quite a well tolerated drug and it is safer to be used. Okay, only side effects include nausea, rashes, that too occur occasionally. Leukopenia also may be seen, but very rarely. So you can see that this drug is very well tolerated. Okay, but the problem is that acute paracetamol poisoning may take place if you exceed certain level of dose of paracetamol. Though it is considered to be the safest of all the analgesics, okay, still there are high chances of precipitation of this paracetamol poisoning, and specifically this acute poisoning may take place in small children who have low hepatic glucuronide conjugating ability. Okay, so remember under the kinetics we have discussed that mainly this drug paracetamol, it gets metabolized by conjugation with glucuronic acid and sulfate. So glucuronide conjugation is the main mechanism by which this drug will get metabolized. So in small children, this hepatic glucuronide conjugation it is less developed. So there are more chances of development of paracetamol poisoning in the small children. Okay, so though it is safe, you are not supposed to administer the paracetamol repeatedly. Okay, so a particular dose in a particular day in 24 hours, it should not be exceeded, otherwise it will start damaging the liver. Of course, we will come to the mechanism also, how it takes place. Okay, this is the fatal dose. Okay, if you go beyond this concentration, that is more than 250 milligrams per kg, it can be quite dangerous. Okay. Coming to the manifestations or the symptoms of acute paracetamol poisoning. Okay. So if you can see that the initial symptoms are quite, not very severe effects are produced, just nausea, vomiting, abdominal pain and liver tenderness. Okay, so these are the mild side effects which are generally produced initially. Though the poisoning has taken place, the symptoms are very, very mild. But after 12 to 18 hours, it will start damaging the liver. Okay, it will start producing centilobar hepatic necrosis. Necrosis meaning the cell death will take place. Your hepatocytes will start getting damaged. And along with this, it will also start damaging the renal tubular cells. Okay, so renal tubular necrosis will also start occurring. This will accompany with the hypoglycemia. So because of all these complications, the person may tend to go into coma after 12 to 18 hours. So initial symptoms were very, very mild, nausea, vomiting, okay, but after 12 to 18 hours, it is progressing up to liver damage and the person may even go into coma. Then after 2 days, jaundice may also be seen, okay, because of the liver damage. Okay, jaundice may start precipitating as a complication. So jaundice is quite commonly associated with the liver damage. Okay, and further complications again will it will depend upon how much of drug is it is consumed. Okay, and this is very important. Okay, fulminant hepatic failure, that is a sudden hepatic failure, and death may occur if a particular plasma level is exceeded. Now supposing if at 4 hours, okay, the plasma concentration was 200 micrograms per ml, and at 15 hours if the plasma concentration was 30 micrograms per ml. Okay, so the line joining these two, okay, if you go beyond this plasma concentration, then fulminant hepatitis or the hepatic damage may be precipitated. Okay. Now coming to the mechanism of toxicity, this is again very important from exam point of view. It has been asked in the papers, what is the mechanism of toxicity of paracetamol? Okay, it has appeared in the question papers before this. So you need to explain how exactly paracetamol is precipitating its toxicity. Though it is the safest drug, it can precipitate the acute toxicity. So what is the reason behind that toxicity? Okay, so this particular reactive metabolite which is generated, okay, it's an intermediate which is generated, that is N-acetyl para-benzoquinone imine, okay, NABQI. So this is a highly reactive arylating minor metabolite of paracetamol. Okay, remember the kinetics we have discussed earlier, that actually paracetamol mainly gets metabolized by the glucuronide conjugation, right? Conjugation with the glucuronic acid and the sulfate. Glucuronidation is the main mechanism by which it is getting metabolized, and this is a minor pathway. Okay, so generation of NABQI also may take place, but it's a minor pathway. So very less amount of this NABQI may be generated. So whatever NABQI is generated, normally it is detoxified by conjugation with the glutathione. So this reactive intermediate which is generated by paracetamol metabolism, it gets detoxified by conjugation with the glutathione. Okay, so normally it will get metabolized. But supposing if you go on consuming very large doses of paracetamol, okay, so in that condition what will happen? Glucuronide conjugation capacity is saturated, which is the main pathway of metabolism of paracetamol. So this pathway will get saturated. So what will happen? Whatever paracetamol is there, it will start getting diverted towards the minor metabolite pathway. This is the one. Okay, so this is actually an insignificant pathway of metabolism. But if larger doses of paracetamol are considered, glucuronide conjugation, which is the main pathway of metabolism, it will get saturated. So more and more paracetamol will get diverted towards formation of more and more NABQI. So what will happen? The NABQI generally it is detoxified by conjugation with the glutathione. So what will happen? When more and more NABQI is getting generated, your hepatic glutathione reserves will get depleted. Okay, so detoxification of this NABQI will not happen. So because of this NABQI, it will start accumulating in the liver, and in the liver it will start binding covalently with the proteins in the liver cells, and of course in the renal tubules also later on. And this is the reason why it is precipitating this condition, hepatic necrosis and renal tubular necrosis. So this is the reason. NABQI, it is not getting detoxified by glutathione conjugation because of the large amounts of paracetamol which are administered. Glucuronide conjugation is getting saturated, more of NABQI is generated which is not able to be detoxified by glutathione. So whatever NABQI is accumulating in the liver, it will start binding to the proteins of the liver cells and the kidney cells, and this will result in the necrosis or the cell damage. Now, paracetamol toxicity, it is of greater degree in those patients who are consuming alcohol, specifically in the chronic alcoholics. Okay. Even 5 to 6 grams per day also can be quite dangerous. It can precipitate hepatotoxicity. Now, why it is dangerous is because alcoholism, that is consumption of alcohol, it induces CYP2E1 enzyme. Now, this enzyme is responsible for generation of this metabolite NABQI. Okay, so more and more NABQI will be generated. So it will not be getting detoxified and liver damage will take place. So in chronic alcoholics, you all must have heard that generally it leads to liver cirrhosis. This is the reason why liver cirrhosis is more common in the alcoholics. Okay, so because more and more NABQI will be generated which will not be detoxified. So that's the reason why alcoholics mostly suffer from liver cirrhosis. Now coming to the treatment, how you can treat this particular condition. So if the patient comes to you within a few hours, vomiting can be induced or gastric lavage or the stomach wash can be done. Okay. Then activated charcoal may be administered, so further absorption of the paracetamol can be prevented. Okay, then apart from this, supportive measures may also be given to maintain the BP or blood volume or respiration, all sorts of things you can institute. And a specific antidote is also available, that is N-acetylcysteine. Okay, so this can be given in specific doses. It has to be repeated in after a certain period of time. Okay, so what will happen is this N-acetylcysteine, so this will help in replenishing this glutathione. Okay, so why a paracetamol toxicity is taking place is because more and more NABQI is generated which is not further detoxified because of low reserves of glutathione. So this N-acetylcysteine, it will help in replenishing the glutathione which have depleted. Okay, so that's how it will help in the recovery. Okay, but if the treatment is started beyond 16 hours, then it will be ineffective. Okay, so as far as possible, paracetamol toxicity has to be treated very quickly. And coming to the uses, as I've told you, paracetamol, it is quite commonly used drug. It is over the counter drug, so it will be found almost in every house. Okay, so in several conditions, painful conditions like headache, mild migraine, musculoskeletal pain, dysmenorrhea, so several conditions where inflammation is not involved because it's a poor anti-inflammatory drug. So such conditions can be effectively controlled by paracetamol. Okay, then paracetamol, it is a first choice drug in osteoarthritis also. Okay, then antipyretic, it has a very good antipyretic property and it is preferably used in the small children. Okay, because there is no risk of Reyes syndrome. This is one more difference. With aspirin, we have seen that in small children, specifically who are suffering from viral infection, so there are more chances of precipitation of Reyes syndrome. So this condition is ruled out with the use of paracetamol. So it is quite safer in children who are suffering from viral infections. Okay. Then again, these are several advantages which are discussed, which we have already considered. Okay, it is safer in terms of gastric irritation or ulceration or bleeding. Okay, then hypersensitivity reactions are also rare, metabolic disturbances are not taking place, and it can be used in all age groups, as we have seen, from infants to elderly. Then even pregnant or lactating women also it is quite safer. Okay, so these are preferably used in conditions where aspirin is contraindicated. Okay, also significant interactions are also not there with this particular drug, paracetamol. So it can be safely combined with the other drugs. Okay. Then the last subclass under this is benzoxazosine derivative, that is Nefopam. This is again a non-opioid analgesic. It actually does not inhibit the PG synthesis. So it is a unique drug, okay, but still it has analgesic, antipyretic property. Okay, so it relieves the traumatic, post-operative and short-lasting musculoskeletal pain. Okay, so it can be used as an alternative to the other analgesics. So if they are not, it cannot be used, then Nefopam can be preferred. The problem with this drug is it has anticholinergic property as well. So anticholinergic side effects like dryness of mouth, urinary retention, blurring of vision may be precipitated, or a sympathomimetic action is seen. So tachycardia, nervousness may be seen as the side effects, and the contraindication is in the epileptics. So in the epileptics, Nefopam is not supposed to be administered. Okay, so this finishes this chapter. So the important questions in this particular chapter is the mechanism of action of the NSAIDs. Either a general question may be asked or specific drug may also be asked. So accordingly you need to give the additional mechanisms as well. Don't end up writing only the PG synthesis inhibition. You have to see the selectivity also. You have to describe about the other additional mechanisms also. Next important question is pharmacology of aspirin is very important. Okay, then the pharmacology of paracetamol, which we have covered today. So that is also very important. Then the mechanism of paracetamol poisoning is very, very important. NABQI generation, why it precipitates the toxicity. Then a note on selective COX-2 inhibitors may also be asked. Okay, so you need to describe all the drugs. Okay, COXIBs. Then advantages of COX-2 inhibitors over the non-selective COX inhibitors, why they are preferred. And of course, difference between any two drugs may also be asked, like aspirin and paracetamol, compare and contrast. So such type of questions may also be asked.